Recording. Perfect. Well, thank you, everyone. And like I said, Ryan, I'll keep checking and letting the people in, so don't worry about it. Okay. Thank you all for being here today. Happy Friday. I was telling Ryan before, of course, our landscapers decided to do the spring cleanup right now. So if you do hear buzzing in the background, I apologize. If you can't hear me, just send a little chat and I will speak louder. But good news is, spring is here, so it's a good sign for us up here in the Northeast. So we'll start by doing introductions. I'll talk a little bit about my background, and then Ryan will do an introduction, and then we'll jump right in. So Ryan, if you want to go to the next slide. Thank you. So I'm Erin Kowalski. For those that are not familiar, I'm one of the directors of business development here at Within Health. I'm a licensed therapist. I've been working clinically in the field for over 12 years now, which is wild. And I started my career, I spent 3 years working at a methadone program. So a lot of what you'll find when I present today is I definitely come from a harm reduction background. So that's where it came from. And then from there, I worked at the mayor's office, the addiction bureau up here in Boston under the wonderful Marty Walsh when he was here. I worked at the PATHS program. So people would come in who were actively struggling with substance abuse, and our team would do assessments, identify the level of care that those patients needed, and we make the phone calls and get them in. And it was my first time experiencing what higher level of care meant. And it's so crazy to think about that I was a master's license leveled therapist and didn't truly understand what higher level of care looked at. And it really was such a beautiful moment for me to understand how impactful that is and how important it is. From there, I went down to Broward County in South Florida, and I worked with the sheriff's office with their mental health team, the task force. So I'd go out with the sheriffs on the 911 calls that pertain to those that were really acutely struggling with their mental illness at the time. I would do an assessment, deem them eligible to go to the hospital or not. And what that taught me was our patients that I was seeing were in outpatient level of care, and they would go to the hospital for a couple days and then go back to outpatient care. And lo and behold, right, I kept seeing the same patients. And it just reignited that idea in me, the importance of higher level of care. So I got burnt out from that job real quick, and then I ended up in outreach. And I've been doing outreach for the past 7 years, and it definitely it's my passion, right? So helping people get to the right treatment is so impactful. And I'm very fortunate, we wear a lot of hats in this role. But most importantly, it's having those conversations with those patients that are on the fence of what it looks like to seek higher level of care. So very excited to share everything that I've learned over those 7 years. And I'm very happy. Ryan and I, this is our second time doing this, and it's a joy having a dietary perspective. So Ryan, I'm gonna hand it over to you.
Yeah, thank you, Erin. Good
Yeah.
morning, everybody. My name is Ryan Sobus, and here at Within Health, I serve as the clinical outreach representative for the Southeast region. And outreach is a bit of a career shift for me. I'm a dietitian by trade, and coming up on 20 years. Prior to this outreach role, I was an outpatient dietitian and owned a group nutrition counseling practice. And so that's kind of the lens that I'm coming from when I'm talking about this, and that truly the hardest aspect of my role as an outpatient dietitian was when I was faced with a patient who needed more support than I can provide. And, you know, what tends to happen in those situations is either A, they're facing true barriers into accessing that support, or even sometimes that patient might lack the executive functioning skills to mobilize themselves into a higher level of care. And so the question becomes on my end, how do I support this patient through kind of a case management that is a time suck for non-billable hours? And also, what are my own kind of ethical considerations and professional boundaries that I bring into that conversation? And so that's kind of a lot of what I am coming from as we're having this conversation. And Erin and I can both kind of share these different perspectives of here's how I think about this from a therapist lens, and here's how I think about this from a dietitian's lens, because we know that these patients, coming from a multidisciplinary sense of care is where we're going to be able to kind of best meet their needs. So I'm excited to be able to dive deep into some of these like more complex scenarios and situations, and we'll take it one step at a time.
Yeah, absolutely. So, like Ryan said, we both work at Within. Today's not a presentation of Within, but I do have to highlight. So, I'm your go-to. If you want to learn more about Within or have any questions or schedule an individual meeting with me, shoot me an email, and we can set that up. Within just a sentence of it, we are an enhanced PHP and IOP at home remote programming for adolescents and adults with eating disorders. So we're designed to be in this space. We're very unique. We are able to provide really customizable care. And I would love the opportunity to explain what that means. And lastly, a quote from our co-founder, Dr. Wendy Oliver Pyatt, that I love. Yeah, here it is. For many patients, being home and being in treatment is really powerful. So, like I said, reach out and we can definitely schedule a time to connect. So next up, we have the agenda. We're going to highlight the common complexities in outpatient care, right? I think it's important to highlight that. Level of care guidelines, breaking down what that looks like, what it means, and why it's important to utilize that in sessions. Identifying the need for higher level of care and what to do when we're in that moment. Outpatient care coordination, why that's important, how we can utilize that to give us the old team perspective when it comes to working on cases. And then our favorite, right? Addressing ambivalence and resistance, and really excited to highlight and get into that. Lastly, we're going to leave some time for questions. We do have a slew of questions that everyone has submitted, but as we go on, if things pop up, I want to make sure that you send it our way. So you can chat it over to us at any point. We will either address it in the moment or we can add it to the end slide. Ryan and I, like I mentioned, we're going to be on for a little bit longer. The content will be within the hour. But feel free to stay on if you want to stick around for more questions.
So, every patient that we see is complex, and eating disorders never exist alone. They're going to come alongside co-occurring conditions like anxiety, depression, substance use disorder, trauma, OCD, and we'll dive deeper into some of those comorbid diagnoses as well. But in saying so, we run into a lot of patients who it's not a slam dunk in terms of what are the next steps and what makes the most sense in accessing care for this patient. And so these are some of the things that I just wanted to highlight that commonly come up in outpatient care. You know, when you are recommending a higher level of care to a patient, sometimes a provider might feel, well, I don't want to break rapport with this patient. I just started seeing them and they really trust me. They're starting to open up to me, and I'm afraid that that trust is going to go away. Transference and kind of bringing up some of your own, biases or belief systems that are kind of coming up for you, not sure if this is the right decision. Maybe we just give it a little bit more time. Maybe we see if things turn around. Am I making the right decision by really kind of putting my foot down and saying that increasing their level of care is the right move? When in the conversation do I bring this up? Is it the first session? Is it 3 sessions in? How do I time this in a way that's going to help meet this patient where they are? Is some care better than no care for a patient who's meeting that recommendation with,
Mhm.
um, you know, resistance at best, but a lot of ambivalence into that recommendation? What does it mean when someone's kind of saying that they're not wanting to take a step further?
And also for me, just hearing you talk, Ryan, and looking through these slides, I just want to reiterate, it is very normal as a practitioner to experience these feelings or these, am I doing it right? Am I not? We've all experienced it. We got to be open, right? Like we've all been in these feelings and it's normal. And it's something that we're all going to experience. And I think we've seen such an increase in people wanting to have this conversation and learn about it. So just want to throw it out there that, we're all in this together for sure.
And we're going to dive deeper into just things to think about when you're coming into these situations. Like, it isn't necessarily a right or wrong answer. These are not black and white. And if they were black and white, then it wouldn't be such a complex, wouldn't be considered complex. But so we'll definitely kind of go into a deeper dive into all of these points. And again, as you have some of your own situations that are coming up that you want to dive deeper into, please feel free to put them in the chat. We'll address a lot of things at the end of this presentation, as well as have time at the end to be able to just hang around and talk about any cases that you feel like would be helpful to run through.
Okay, so level of care guidelines. I know that we're all familiar with what these terms are. What I want to highlight is the importance of understanding that our patients do not, right? So What I have found helpful is, as you know, when you are starting with a new patient, you have a treatment contract that you review, the patient signs. Oftentimes, right, we include mandated reporting and we discuss what that looks like. We paint the picture to the patient of if you're at harm to self or others, these are the steps that we're going to take. Do we agree? Yes. Well, what's also really, really important is this, right? Is reviewing what this means and what it looks like with our patients. So you can do it day one, you can do it with your caseload now. I always recommend even just reviewing it, right? You will always be stuck when you're meeting with a patient for X amount of months and you have the conversation with them. You know what? I think it's time for higher level of care. We need to look into PHP residential. If it's the first time that that patient has heard those words before, you're already in the background, right? You need to be more prepared. And doing so is reviewing what these mean. First and foremost, language is important, as we know. Again, as a therapist here, language is highly important. When we're saying and reviewing these, PHP stands for what? Partial hospitalization program. That sounds terrifying. As we know, most PHPs are not in a hospital. So, really breaking down and understanding what this looks like. Residential and inpatient, all we know, all of our patients know is what they've seen on movies and TVs. So, really being able to paint a picture of what this looks like is important. Part two, we live in outpatient, right? With that being said, we need to be very specific and transparent with our patients of what that looks like. And what that looks like for me is going to look different for you. So, taking time as an individual practitioner to evaluate what are my boundaries? What is my ability to provide care for patients on a spectrum of acuity? Where do I draw that line? I need to understand what I'm comfortable with as an outpatient provider so that I can say to my patients, this is what I can provide. I can meet with you once a week, every week. If you need more than that, these are the options of what it looks like. Also, another thing I like to highlight, there's also from outpatient to IOP, there are more steps to take. So if I have, we all have that gut feeling, right? The gut feeling that a patient might be needing more than we can provide. I will start by saying, hey, listen, why don't we attend just a group virtual therapy session, one that specializes in, let's say, OCD or anxiety or males. Let's just start there just so they get comfortable with what that looks like. But like I said, I really think this is important to highlight as a first step when working with patients.
One of the things that I also want to bring, awareness to when we're looking at this chart is that when someone is moving from outpatient level of care into a higher level of care, it doesn't have to work like a ladder in the sense of someone can step directly into whatever level of care is going to be most appropriate and best meeting their needs. I also think that sometimes when we're waiting until medical crisis, when we're waiting until that place of needing medical stabilization and hospitalization, it can be a traumatic experience for that patient of having to kind of like swoop in. It can also mean that their length of treatment is going to be much longer, and meaning that we're going through all the steps of inpatient to residential to PHP to IOP. This graph, while the first one kind of highlighted someone's own willingness and readiness and motivation for recovery, this one kind of looks a little bit more at behavior use specifically. And I had, this is straight out of the APA practice guidelines. However, I had one made for my practice that also included weight restoration and where someone was in terms of a weight suppressed range. And so we were able to look at varying degrees of weight suppression. And one of the reasons that that's so important is because at an outpatient level of care, the most weight restoration that I'm able to really achieve successfully is maybe half a pound to a pound a week, 3 out of 4 weeks. So if someone is needing to gain 20 pounds, then we're looking at 10 months that someone's remaining weight suppressed until they're getting to their expected body weight, even if they're motivated, even if they have support, even if they're following their meal plan 100%. And so there might be certain criteria that I'm looking at for someone to say, is it safe for you to remain in an outpatient level of care if you're less than 80% of your expected body weight or 85% of your expected body weight, depending on the level of weight restoration that's needed? And for someone who's maybe under the age of like 25, then we're looking at, does this disrupt their long-term bone development? Does this disrupt their, prefrontal cortex and their fully like their cognitive ability to be able to look at like futuristic thinking. So I factor that in when I'm making the decision of kind of a harm reduction approach or meeting someone where they are. Age is going to be a factor, as well as how is that kind of medical presentation affecting someone's ability to be able to be medically safe and stable. So we're looking at not only weight, we're also looking at purging incidences, we're looking at compulsive exercise, and then we're kind of looking at their emotional support. So this is also a really great, we'll make sure that you have a copy of this kind of as a whole table, but it's helpful in kind of explaining these different levels of care to patients as well as where they're falling in terms of their own level of acuity.
So here are some options that you can utilize in sessions um, to get a gauge of where your patient lands on the scale of severity. So the SCOFF questionnaire, it's brief, it's 5 questions. I recommend more just having it as a casual conversation and making notes to yourself. And then the EAT 26, it's more of identifying the at-risk patients. So that can be really helpful of if you're really, considering this patient is not appropriate for your level, this helps give you guidance where they land. And then the EDEQ is a 28-item questionnaire, and it really helps look at the symptomology, and that's helpful to track patients over time. So this is a full separate presentation, but just wanted to throw this out there so that you guys have this as tools. Also, it's really helpful and we'll talk about working as a team, like this is a good conversation starter to have when you're working with, from a team mentality.
And I just want to echo what Erin said about this being a whole separate presentation. If you are a primary mental health provider or maybe working with patients and not necessarily an eating disorder specialist, but really wanting to kind of do a deeper dive into how can I catch my patients that I'm working with that are presenting with an eating disorder and I might be missing it, Erin and I are happy to provide that presentation as well. So just let us know. All right. Let's see. When you are conducting these screenings and you're looking at the SCOFF and you're looking at the EAT-26, how does that help you indicate whether or not this patient actually needs a higher level of care? I think back to that SCOFF questionnaire, and it was like, if you have 2 yeses to this questionnaire, that means that an eating disorder could be present. Just because an eating disorder is present doesn't necessarily mean that we're all of a sudden like whisking them away to a higher level of care. And so these are some of the considerations that I would take into account when I am thinking, is it appropriate for this patient to really kind of get the support that they need that might be more than what I can provide. One of them is that weight changes of concern. We spoke to this briefly when we were looking at the levels of care guidelines. And, what I would often echo to pediatricians is if I see 2 lines on a growth curve, that's when I really want to make sure that that patient is getting the attention that they need, because that's a trend. A growth curve should not look like a roller coaster. And so if we're seeing those 2 lines in a growth curve starting to move, then that might be one of those places. Or if we're seeing this kind of like rapid decline of 10% of someone's body weight, or if someone has been hanging out at 80 to 85% of their expected body weight, then that might be a consideration of, do they need more support than I can provide right now? If there's a rapid or persistent decline in food intake, and this comes back to both the weight changes of concern and the decline in food intake. Is this patient at risk for refeeding syndrome? And why that's so significant in the outpatient level for a dietitian is it changes my role in this case. As an outpatient level of care, my role is typically going to be, we're going to do mini planning, or we're going to be able to take a look at, how are you meeting your needs on a daily basis at an outpatient level of care? When I'm starting to worry about refeeding syndrome, I'm starting to worry about lab values. I'm starting to worry about really having to micromanage this patient's carbohydrate intake to minimize risk for refeeding. And the challenge in doing that in an outpatient level of care is I don't have access to the lab values, and I don't have access to the medical support that I would typically have in a higher level of care setting. So this patient is kind of asking me to step outside of my role and take on more responsibility than I typically would in my role as an OPRD. If they are consistently just unable to decrease symptoms, we've put all the interventions in place, we've been monitoring this on a consistent basis, and they're just kind of steadily staying in this place of holding on to those behaviors, then that might give you the indication that more support and accountability can be warranted. We're going to kind of take a deeper dive in the next slide, talking about co-occurring psychiatric disorders. And the thing that I think is so important to take into consideration there is that when you're providing, it's kind of like a whack-a-mole situation, right? Like when you're providing a lot of support and accountability on one aspect, like let's say we're doing more ERP for OCD. If we're doing more exposure prevention for OCD, then that might mean we're seeing an uptick in those distress behaviors somewhere else. And so being able to be in an environment where they have more containment and more support around all of those is one of the things that can kind of really help move the needle, as well as decreasing their just when you're looking at someone who's just really kind of starting to decline in their day-to-day function. And when I'm taking this into consideration, the thing that stands out to me the most is one that actually our co-founder, Dr. Wendy Oliver Pyatt, speaks to frequently, in what moves the needle in terms of the patient's recovery. And it's two things. One, having providers who are knowledgeable about eating disorders, because I think that that makes a huge difference in terms of access and early intervention to specialized care. And the second thing is a patient hearing stories of recovery from people with lived experience. And that's where I think group settings can be incredibly powerful. And so, even if that's something that's an adjunct to the outpatient care that they're getting, or that's something that's going to be kind of naturally part of their higher level of care experience, it can make a significant impact in their own ability to make some strides.
And going off what Ryan said, and I know the next slide shows the our patients are struggling with co-occurring psychiatric disorders, right? And we know that. And having those conversations up front with our patients are really important. So Ryan, you can go to the next one. And like Ryan was saying, a lot of times our patients, they say things like, well, okay, you want me to go to care for eating disorders, but like my anxiety is so high. And what does that say to me? That means that they don't understand what it looks like. They just think they're going to be treating just eating disorders and we're just going to be talking about food. And that's not the case, right? So as a therapist, I say, okay, well, let's dive into that a little bit more. This program can also address your anxieties in this ways, A, B, C, D. We know a lot of times someone's depression is a big, big, big barrier why they're refusing to get into more care. Okay, right? We know that. We understand that. You have to meet that with compassion, right? And really highlighting the progress that they have made thus far. And knowing patience is huge, right? Our patients aren't, no one's excited to go to higher level of care, right? And I always say that. I'm like, listen, you're not the only patient that's like really hesitant here. Um, and just reminding them of it's not a failure, right? Because that's a big core belief, right? I'm a failure if I need a higher level of care. And we need to be the ones that are changing that script for them. A conversation that I have pretty often with patients is, listen, we're talking about a whole new way of life, right? We're talking about relearning how to feed yourself, learning how to understand nutrition and thinking patterns and your way of life. Like that's a big hill to climb, right? And you can't do that just from seeing me once a week and seeing a dietitian once a week. We have to go to school, right? We have to learn how to do this. And a lot of times it's not that you're failing here. It's just there's not enough time. There's more content that needs to be provided to you that we can't do once a week. That's why we have these options of higher level of care. And it's really important to explain it that way and leaning into going to school and learning more than treatment, go back to that language can really kind of shift their perspective and their motivation. I always like to highlight here trauma is a big reason why patients refuse to go to care. Unfortunately, we've all had patients that have treatment trauma, which is a big reason why they're very hesitant. And I think that's why we're so lucky with virtual care. That is an option nowadays for higher level. So having those conversations with patients, you get to stay at home and feel in a safer place. Another thing that's really helpful in kind of changing their perspective is, always what would you say if this was someone else you loved that was really struggling, right? Like paint that picture, play that tape through, or reminding them that most eating disorder behaviors, right? That's self-harm and it's self-harm. And oftentimes it's really explaining to them what's happening to the body because oftentimes they're just so living Their head is where their feet are, right? And we need to get them to really understand what's happening and paint that picture, so that they really know the importance of why you're pushing for them.
And so kind of coming back to this is just a summary of what we've discussed in terms of what moves the needle when someone is able to really kind of start making some strides towards baseline. And early intervention is key in making, and early intervention can mean a lot of different things, but it's essentially making sure that this patient is connected to specialized support, and providers who have eating disorder specific experience. We're looking at incorporating evidence-based treatment. And I know here within that's going to be a variety of things from like whether it is a variety of clinical modalities, DBT, ACT, CBT strategies, DBT, CBT-AR, RODBT, but there's an alphabet soup in terms of kind of the lens of which we're providing support. And then again, coming back to the hearing these stories of patients with lived experience through that social support is something that I think can be really critical.
Yeah, and I can't stress this enough. Okay. And it's just one of my core beliefs, right? Is I know everyone is so busy. It is overwhelming to have the schedules that we have. However, you have to, Ryan and I, we do outreach, right? So it means we represent companies, we understand the program in and out, and we can explain the programs. There's our roles in every program. And I highly suggest that you meet with us, outreach members, to learn about the programs and ask the questions, right? Evidence-based treatment, what does that look like? Every program provides different modalities, like Ryan mentioned, different care, different age populations, and really understanding the outcomes. We want to make sure when we're referring to a program, it's a lot of ownership on that, right? It's us putting our name on it. And matching patients to that program is so important. So you never want to be stuck in, okay, we need to go higher level of care. And they go, okay, where? And you're like Googling where to go, asking ChatGPT. We don't want that. Use outreach members to understand the program. And another really helpful tip is when you are looking into programs, Ryan and I, outreach people, can also hop on a phone call, and we can hop on a phone call with just the patient. We can do the three-way where it's all of us on a call to really make sure that the patient understands, ask questions. So just that's my tidbit, just highlighting the importance of getting to know the programs that you're referring to.
I want to take a moment, Erin. We had a question that came through the chat that I think might be helpful to just put some context to here now. Mallory is reaching out to kind of say, as a therapist, how can I support a dietitian or a physician in making the decision to make the recommendation to a higher level of care? And I think that, we're heading into the conversation. And Mallory, I love the softball that you gave us right now because we're about to cross into, outpatient care coordination. And so hold on, there we go. Coordination among outpatient team members. And I love this question because you're right. As a therapist, you can't look at someone and know whether or not they're sick, and you can't look at someone and know whether or not they're meeting their nutrition needs. And so pulling in a dietitian, and I always recommend this whenever even a primary mental health or an eating disorder specialist therapist is working with the patient, it's always helpful to just get a pulse on how a patient's doing and kind of meeting their nutritional needs. But I'll tell you how I, as a dietitian, really rely on the collaboration of working with a therapist. And when I'm making these recommendations and I'm helping this patient with nutrition interventions, that patient is holding on to those behaviors as a coping mechanism. And I don't necessarily know um, to the extent at which have that grasp in terms of their own level of safety. And so for a lot of patients, what we often see is we have this opportunity to stabilize, and yet every time someone is engaging in maybe a deeper trauma therapy, and so like they're getting deeper into EMDR, for example, we're seeing this uptick in behavior use. And so kind of round and round we go. So learning from that therapist where they are in their recovery. And is this the kind of thing where we kind of have to provide more wraparound support while this patient is getting deeper into that therapeutic process? Or is this just a situation where um, everything is stable in their life except where we are in recovery for their eating disorder. And so I think that therapists can sometimes, for me as a dietitian, put context into how these behaviors are showing up. Erin, does that make sense to you on your end?
It does. And one thing that again, going back to the slide where it breaks down the levels of care and we're in outpatient care and holding our own boundaries, for me, a boundary is if I'm working with a patient with an eating disorder, they have to have a dietitian who works with eating disorders, and I have to have an ROI. That's just like my preference. That's how I have found recovery to be more effective. And I know the importance of working against the patient splitting, right? So oftentimes, if a patient comes to me and says, well, my dietitian said this, or I know you're recommending a high level of care, but my dietitian said that. I say, okay, well, let me touch base with the dietitian and then we'll come back to it. I never feed into it, right? You have to make sure that you're really holding strong boundaries. Um, and also, oftentimes, when patients sometimes they want to spend the entire session talking about food with me. And I always have to stop them and say, this is a great conversation to have with your dietitian. What we're going to talk about today is everything underneath and drawing out those emotions and dysregulation, right? So again, boundaries and guiding back to the correct discipline.
And also that therapist giving me feedback as I'm incorporating nutrition interventions, how is the distress escalating? Is the distress escalating to a place that this patient feels like it's intolerable? And that's when we know that providing more support is something that can be really helpful. Or are the interventions that I'm putting into place, causing exacerbating their levels of distress? And so do I need to kind of back down how aggressive we are in making that progress? But I love coming back to kind of what Erin was mentioning in terms of having ROIs, and not only having ROIs in place, but also communicating what is your communication preference? Do you prefer to communicate over email? Do you prefer telephone calls? Do you prefer having a team meeting over Zoom? Um, how are we going to collaborate? And that's one of the things that I think if you've ever worked in a higher level of care setting, that kind of is built in, where you have these multidisciplinary team meetings that are happening and kind of roundtabling around each patient. The hard part about patient level of care is that you have to create that in like non-billable hours, and you have to kind of get on the same page of that provider in terms of what their time availability is. And so I do think that's one of the things that you have to work a little bit harder to make happen in an outpatient level of care, but still super important to do.
And I just have to highlight this. I know we're a little behind. However, what I get asked pretty often when patients are looking into higher level of care is, can I still work with my outpatient providers? And to me, right, what does that say? One, that they have such a beautiful relationship and rapport with their providers. Um, and two, they didn't want to let that go. And understanding every outpatient provider is different and what they're able to do. Some will continue seeing the patient on a weekly, biweekly session. Some will say, hey, listen, while you're working with that team, why don't we set up 15-minute calls every other week just to do a check-in? Just reassuring in that sense. And then also reiterating, once you complete that level of care, we'll continue the work that we're doing. So I wanted to highlight that because that's something we see pretty often.
Mhm. And so sometimes when we have that kind of consideration when we're talking about complex considerations and higher levels of care around when do I have this conversation? And one of the things that I always would do in my own practice is up front, here's what is appropriate for me in terms of working with me in the outpatient level of care. The first thing that we're going to do together is kind of assess what does it mean to be appropriate in outpatient care, and where are you currently in that, spectrum? I'm also going to make sure that I have an ROI in place that you're working with a physician. As much as I can kind of go through a nutrition evaluation with you, I can't look at you and know what your labs are. I can't look at you and know what your vitals are. And so making sure that you have had a recent visit with a PCP. I also want to make sure that you've had an evaluation with a therapist or a psychiatrist, and that we have ROIs for a therapist on board. And a lot of that is because, as a dietitian, I um, can work with you on regulating intake and normalizing food intake. However, we know that manipulation of food and body is often a means of coping with some type of psychological distress. And I can't work with you on developing skills and tools to stabilize that. And so that's where this comes from, like a multidisciplinary standpoint. And I can put all of these things in an outpatient kind of treatment agreement up front and talk about these are things that are a requirement for me as your provider and continuing to work with you and meet with you in this space. If anybody wants a copy of like what a sample language of this would look like, I'm happy to provide it. I think that at the end of the day, we're communicating that the recommendation to a higher level of care is not punitive. It's not because you didn't listen to me. It isn't because you didn't do what I asked you to do. It's because this is where I can meet you and I can support you. And when we extend beyond that, it means that you're needing more support than I can provide. And what I'm asking you to do is really hard. Let's see. I had a, yep. Happy to share that, Bonnie.
So going into addressing ambivalence and resistance, there's two different ways of looking at this, and both are very, very helpful. One, we want to make sure stages of change, right? Always kind of going back to, I'm having conversations that are meeting the patient where they're at, and evaluating where they are in this wheel. And then the vitals conversation starter is a great way of really kind of checking in and learning different techniques and skills when those patients are in the pre-contemplation, contemplation, when they're in preparation. So kind of matching where they are, and you can kind of jump in at any stage, not, doesn't go one by two. So first up we have V is validate. So crucial and important, right? So our patients at this point, right, they are at a low point and they're not having a lot of motivation. So just having open-ended questions. What are your fears? What are your barriers? Let's talk about them. Let's spend an entire session talking about what are your hesitations to, looking into this and understanding what it is. A big reason that I learned over time, which I didn't know in the beginning of what holds patients back from seeking higher level of care, is the fear of letting go of their eating disorder, right? And I heard this analogy a long time ago, and I love using it with patients of when you, right, like when you're in a river and you're drowning, you just feel like there's no way out. You are struggling at the highest degree. And then you see a very sturdy, stable log floating by. What are you going to do? You're going to reach onto it. It's going to keep you afloat. It's going to give you the breath. It's going to stabilize you. It's going to get you through the rapids. And then after time, it calms down and you're just floating down the stream. You have to make that decision to let go of that log to get to the land, right? And oftentimes, I reiterate with patients that your eating disorder behaviors, it's a coping skill, right? It's maladaptive, don't get me wrong, but it's a coping skill. When you were feeling so dysregulated, you participated in X behavior and it gave you that sense of comfort, control, numbing. Validate that, right? And it's scary to take away that log when our patients don't have that confidence yet. So having that conversation with them of, yeah, it's scary to let go of it. And your eating disorder has been there for you for so long. However, in letting that log go, you get to reach the land, and the land is so much space to explore and things that you can never even think are possible. So I love using that in an analogy for patients that are in that phase.
Mhm. And I love this acronym, the vitals. And for me, oftentimes having this conversation of going to a higher level of care, I have so much in my brain and I have so much that I want to communicate that it's hard to know where to start. And so, what I love about this kind of step-by-step approach is that it's a way to give me language and it's a way to take my time and not feel overwhelmed when I'm having this conversation with a patient. You know, as a dietitian, I am not a DBT trained therapist. And so sometimes knowing where to go and knowing where to have the language around meeting a patient where they are is something that is challenging. Like I know the science behind where they need to be, and I know that they're not there. And so obviously that's where we need to go. And this has been really helpful as a tool for me to be able to know how to kind of meet somebody where they are and how to take it step by step. And so starting with this, like validate to me everything that's going on with you. Why does this feel so hard? Can be really eye-opening too in knowing where they're coming from. I had a patient, and this was kind of in the throes of the pandemic when it was really difficult to get patients into care, and we were facing wait lists everywhere. And I watched her BMI dropped like a stone when we were on a wait list and going into a higher level of care. And when we were kind of talking about some of the pros and cons, we had a bed available, and she all of a sudden didn't want to go. And she was hemming and hawing and spinning, and I couldn't understand why. Like, we've been waiting for this for so long. And it was because her dog had a scheduled teeth cleaning during that time. And she was like, well, I have to take my dog to the dentist. And for me, that seems very trivial in terms of this being like a life or death situation. But I think the thing that was really helpful for me to remember is that in that place of where she was and being malnourished, she had this kind of very black and white way of thinking and this very rigid way of thinking. And it was really difficult for her to step back and problem solve. And so giving her the space to validate all of the fears that she was coming up with helped us problem solve together so that she wasn't in a situation where she had to figure that out by herself.
And then going into imagine, right? Imagine the steps that are involved in doing this. Um, who would you tell, right? Even, how would you arrange time away? What does your typical day look like? I had a patient once who was really hesitant and I was like, well, like what is the big issue? Like what are you nervous about? Like think about your first day. Imagine going on the first day. And their response was, well, is it like jail where I like get stripped naked and they give me like an outfit to put on and like right, and we don't know what our patients are picturing, right? So it's asking that question like what do you think a day or your first day would look like? I've had patients who their biggest fear, like Ryan was saying, was like, well, I have a favorite necklace, like do I have to take it off? Or I really love wearing fuzzy socks at night, what if I can't do that? Can I call my family, can I call my loved ones, right? And these are all just valid questions, so providing those answers to them makes the biggest difference.
And also just imagine like what would happen if we don't do anything? Nothing happens if nothing happens. And so let's play this tape forward. If we don't make any changes, where does this go? And that I think is really a helpful imagine tool to incorporate in here as well. And
Mhm.
it's just this magical thinking that this is going to go away on its own and that there are no problems that are going to come of it and I am going to be fine. And so being able to talk through some of the more immediate consequences of changes um, I think that that's a huge thing to be able to meet them where they are there.
Yeah, and the medical behavioral, right? And the conversations that I've had are a student athlete who needed PHP residential, and she's like, "Well, I hear you and I understand what you're saying, but I'm the best player in my team. So how can you say that my body's not functioning well? But like, look what I'm doing, right? As because a big part of it is, reviewing. I always say, like, what is our body telling us, right? Let's review what the medicals are saying to us. And I rely on the dietitians oftentimes for this. Um, and then from the therapeutic approach, it's like, you're right, right? That's true. You are the best player, right? On the field. And imagine what it would be like if we were giving your body the fuel that it actually needs. How much better would you be? Right. So, like, making sure we're painting that realistic picture for them. I had a patient, another one who is really just anti everything until I talked about how infertility can be affected long term, futuristic thinking. And it's important to have the futuristic thinking conversations. Like I said, oftentimes head are where the feet are, rather than thinking about the future. And for her, that was her aha moment of, oh, wow, I didn't know that. I didn't know that this could impact me as potentially being a parent one day. And again, it's not fear-based, but like kind of, it's reality-based, right? Like this is the reality of what eating disorders can do to the body. Oftentimes I have those conversations with family members as well. Families, for some reason, right? And I say to them, if your daughter was struggling, your son, your child was struggling significantly with addiction, with substance abuse, you would jump right on to getting into treatment. But for eating disorder, there's a lot more shame and stigma or belief that nothing's really wrong, right? Until you have to like highlight what the body is saying to us is something that I often use with family members. And with family members across the board, I think it's always helpful to tell them, this is not your fault. You did not do this, right? And allowing them to understand and feel that, and then give them the tools to provide appropriate support for their loved one getting care. But we can't just ask them to do it. We need to address their fears, their guilt, their shame, and then guide them in the way to provide support. And again, that's like a whole nother presentation, but just throwing that one out there.
This one's take small steps. Like, what's one thing that we can do? And this is where, with the clinicians that I work with, I'm like, just loop in Ryan. Like, let's just call Ryan, or let's loop her into our session, or let me introduce you to her. Because I feel like both Erin and I can be like a warm handoff or a warm place to land. It could also be just like contacting admissions to be able to get more information, regardless of what program you're looking into, as a way to just gather more information. The take small steps is us just making an informed decision. It doesn't mean that we're making any commitments to anything yet. I also like to highlight, what if you just told someone that we had this conversation today? Who's in your inner circle that you could say, whether it's a roommate or a friend or a family member, that you and I had this conversation. Again, helping them make it more real and helping them tell that back to someone else, I think is one of the things that can really help, bring that conversation to life and make it reality.
Or applaud your efforts. This is my favorite. I think we really need to be the biggest cheerleaders for our patients. Specifically for me in outreach, when I'm in the outreach role, if that patient makes that the provider says, I want you to look into within, I want you to call Erin. When they call Erin, and when they call me, and I have a conversation with them, there's a lot of gentle support and guidance. But at the end, I always say, this was a very big step. And I hope you feel proud of the step that you made because it is. And I think oftentimes when we're working in the field and we have X amount of patients all day, every day, and we're kind of like in the nits and grits, we forget how these steps are really, really big for our patients to be doing. So applaud, applaud, applaud. I can't highlight that enough. I always like to, going back to my clinical side, when I'm having these conversations, highlighting when patients are like, I can't do it when they don't have the belief in themselves. They don't believe they can do it. I always say, well, let's look back on time. Let's look at history. And I'll pull up the treatment plan. I highly recommend, I think it's always so important in the first step when you're creating a treatment plan, make it as structured, as specific as possible. You're going to thank yourself later in moments like this, where you're like, let's look back and see how much progress you've made. Because I think when we're working with patients for so many months or over, the years, it's like they don't realize how life was back then. So it's
Mhm.
nice to remind them, like, I know you feel like you can't do it now, but look at all you've already done. And if we're looking at the evidence, like, look at how incredibly strong you've been throughout this time. Let's take that and keep moving forward, right? That's a really helpful applause to use in the moment.
And I want to come back to Mallory's question here around how can a therapist support a dietitian? A therapist can support me here, and what's an appropriate amount of applause in this situation? And, if I'm working with a patient with, borderline personality disorder, what type of applause is going to be appropriate in that situation? Maybe I don't want to say, I'm really proud of you. Maybe I want to make sure that I'm holding that boundary of like, you should be really proud of yourself in this moment. I might have some patients that are going to be more receptive to praise. I have patients that might be really resistant to it. So I'm going to lean really heavily on working with my therapeutic counterpart to say, how can I applaud and support this patient in a way that feels clinically appropriate for them right now? Lighten the load. What can we do to make this a little bit easier? What options do you have? Can we explore that together? Can we medically underload if you're a student? Can we reach out to FMLA? Can we reach out to someone in your circle of support that can kind of provide support? These are all things that we can kind of take a look at. You don't have to do this alone. And let's identify your resources so that this doesn't feel like this is all like resting on you.
Yeah, I call it bounce passing. What can we bounce
Yeah.
back? What can we bounce pass off? And I also think it's important, and I really stress it. This sounds easier than it is, right? Because oftentimes, as we know, our patients, they thrive in isolation. They don't want others to know what's going on. So being able to call that out, right? If we really want to work and strengthen our recovery voice over our eating disorder voice, we need to change our entire environment. That includes our family and our loved ones. Which again, that's like a whole separate conversation, but it's important just identifying that. Like it's really difficult to go through this alone. And the
Mhm.
more support that you have, the better. So what does it take for you to feel comfortable allowing these individuals into this space? And then like let's start those steps.
Yeah. And then my last one is the sweeten the pot. And I come back to, I was at a conference one time and I heard Jenny Schaefer, the author of Life Without Ed, speak.
Mm.
And it always stuck with me. And she mentioned, in order to recover from an eating disorder, you have to have two things. One, you have to want something more than you want your eating disorder. And two, you have to be willing to be uncomfortable in order to get there. And so when we're talking about what's the why, some patients are going to be motivated by a carrot and some patients are going to be motivated by a stick. But it's our job as a provider to understand what's the crack in the foundation, what are the things that are keeping them from doing the things that are really kind of important to them. So a lot of values work in terms of what do they value in their life and how is the eating disorder kind of interfering with their ability to get there. And it kind of came back to what Erin was speaking to in terms of that one patient that was really worried about her future fertility health. That was more of a stick. And it was one of those things of like, I don't want that to happen. And so I want this to, I value this. Or, it could be a patient who, again, I was working with an ARFID patient one time who had recently divorced and his wife left him because they couldn't go out to dinner. And it really affected their social life. And so he was like, I really want to expand the variety of my food intake because it's really limiting my social life and isolating me. And so he was at the place where he was ready to make that motivation. And so, again, helping them identify their why and then helping them find the support they need in order to be able to move that needle. Okay, we've come down to some questions. And so we certainly don't have to read these line by line. Erin, how do you want to tackle this?
Yeah, and they're all such great questions. I know we addressed probably some of them throughout here, but I'm just looking quickly. What do I do for a patient who's at a subclinical level but not making any progress? It's a great question. Um, and I think it's important to, like I said, I love group therapy. I think it's so powerful and can be so impactful to get patients to that next level. So that is an option saying, hey, let's add on a weekly group. Another option would be, let's say I'm working with someone with an eating disorder, but they have significant trauma or significant OCD. I would say, you know what, let's pull in an EMDR specialist. Let's pull in an OCD specialist to work, alongside each other. Um, and also I've had conversations with patients of like, listen, I feel like we're at a plateau, right? And is this something where maybe we should look at other options for therapists? Maybe it's we've done all of the work that we can do together, and maybe we need to have another perspective, another modality, right? Like I know my wheelhouse, I know what I'm really good at, I know what I cannot treat. I can't treat everybody, right? I'm not supposed to. I'm a CBT therapist. That's where I strive and I hone in on. And it's okay to say, and oftentimes patients think this themselves, but they don't feel comfortable bringing it up. So it's our responsibility to have that open conversation. I say that right from the beginning. I do a mid check-in and at the year, like do you think we are doing? And asking for feedback. I think that's been really helpful.
Mhm. And one of the things that I see as a common theme in a lot of these questions is, when do I stop treatment if a patient refuses my level of care recommendation? Or if there's a patient that I'm working with that's refusing my recommendation, what do I do? It's really depends state by state. If you're terminating care with a patient, I know that here in North and South Carolina, providing advance written notice